My name is Nic Reus. I work as an ophthalmologist at the Amphia Hospital in the Netherlands.
My name is Ramin Khoramnia. I work as an ophthalmologist in the University of Heidelberg. Yeah, Nic, you're obviously a well-known expert in the field of biomaterials as well as in the field of stray light. Maybe could you explain us what stray light actually is?
Well, stray light is an optical phenomenon where light is being scattered by very small particles in the eye. And it creates a veil of light over the retina, and thereby reducing contrast, inducing disability glare, difficulty with looking, seeing faces when looking into light, and also spatial disorientation can occur from stray light.
And does stray light always have an effect on visual acuity?
No, it's very different from visual acuity. So stray light is more about the veil of light that covers the retina. So often people with, for example, people with cataract, they have an increased stray light. And it's possible that, especially with subcapsular posterior cataract, they have very good visual acuity, but they have a lot of complaints about glare. And that's because of the stray light. But because the light is being scattered over the retina, it reduces their contrast and they have a loss of visual quality. But still a lot of light reaches the fovea and you still have under good visual circumstances, have a good contrast and good visual acuity. So if you measure in the clinic, you measure the patient with the eye chart and you have a dark room and only the letter box is being illuminated, they have a very good visual acuity. But if you then would introduce a light that shines into their eye, then their visual acuity would go down because of the stray light, because of the loss of contrast.
Mm-hmm. So then we definitely should also assess not only visual acuity, but always look at visual quality as well.
Yes, it's very important to do both. So for the indication, I think for cataract surgery or any complaint about visual quality, I think it's good not to just test visual acuity under ideal circumstances, but also either ask the patient about their perceived visual quality or even test stray light in the eyes.
Yeah, Nic, could you maybe explain us what impact glistenings can have on stray light?
Well, glistenings are very small vacuoles inside lenses, especially hydrophobic lenses, and they induce stray light. So the light that hits such a vacuole, such a glistening, is being scattered, and that induces stray light. One of the things that ophthalmologists thought is that these glistenings are very well seen by the ophthalmologist when we look at the slit lamp at these eyes. So the amount of light that is scattered backwards, the backscattered light, is very high in these glistenings. So when we look at the slit lamp, we see the backscattered light, and that's very bothersome for the patient or the person who looks into the eye of the patient, because he sees a lot of backscattered light. But interestingly, the amount of forward scattered light, so the light that is being scattered forward towards the retina, is relatively low. So the patient is not as bothered by these glistenings as the ophthalmologist is when he's looking into the eye. So there's a discrepancy between that. But there is some forward scattering of light by these glistenings, but the amount of scattered light is relatively low. So we looked at the relationship between the number of glistenings in IOLs and the amount of stray light that would cause that. And what we looked at the various publications about the number of glistenings in lenses in the clinical setting, the maximum number of glistenings that has been reported doesn't produce that much stray light in an eye that it would be clinically bothersome to the patient. So in essence, yes, glistenings do increase stray light in eyes, but from a clinical point of view, for the patient, it's not that bothersome.
Okay, so there is a relationship between stray light and glistenings.
Yes.
But you would suppose that glistenings only become relevant if they are present in a very, very large number.
Yes, and a very, very large number that is clinically is not seen exactly. Yes.
Yeah, Nic, do you have experience with the Clarion Autonomy injector system?
Yes, I have experience with the Clarion Autonomy system, and I think it's a very easy to use system. It's very different from what we used to use. We use a screw injector, and this is a single-handed system. It's very easy to prepare by the nurse, by the operating nurse. As you said, you take off the cap, and then you, with a small lever, you advance the plunger, and to preload the IOL in the correct position in the cartridge, and you dock the cartridge into the main incision. It's a wound assistant technique. It's a very nice docking system, and and then you can implant the IOL, and it's a very controlled way of implanting the IOL. I like it very much. And you can use your second hand then also to stabilize the eye. We almost only do topical anesthesia, and it's always a bit difficult for people to give some counter traction so that they don't move their eye when we try to implant the IOL. So it's nice to have a second instrument to stabilize the eye, and that's very easy to do with this Clarion Autonomy. And I like it very much.
Yeah, the device also has a depth guard. What are your thoughts about the depth guard?
Well, I do like it because with the depth guard, there's a smaller at the tip. The diameter is a bit smaller, and you put that into the incision, and the depth guard attaches to the outside of the cornea. So it gives you a lot of control to remain in contact with the incision and give you a good control on the implantation of the IOL.
And I think it also helps to protect the wound, right?
Yes, it does help to protect the wound because it has been developed to fit into this incision, and the IOL also is being pushed through the depth guard or through the cartridge within the incision, so it doesn't stretch the incision that much, I think. So it's really nice, nicely developed. And also like the Clarion lens itself, because the Clarion Autonomy comes with the Clarion lens. It's a very clear material. Sometimes it's difficult to see in the eye after implantation at the slit lamp when the patients return for their checkup. It's a very nicely clear material, and I'm very satisfied with both the implantation of the Clarion Autonomy and also the way the IOL looks inside the eye.
So although you said that glistenings do not really cause too much stray light, you still would prefer a material, or still prefer the Clarion material because it's completely free of glistenings?
Yes. So when looking at different materials, I agree with you that you need to strive for the best material out there. And although some materials clinically may not be important with regard to stray light, I think you want the best for the patient, and you would like to have the most clear IOL, and the Clarion Autonomy is a very clear IOL that doesn't show any glistenings in that sense.
Yeah, Nic, it was really a pleasure to have you here. I wish you a very successful rest of the Congress, and maybe see you next year.
Thank you.